Hi, everyone. Thank you so much for joining us for today's webinar. My name is Brandy Thomas, and I'm the producer for Texas Fertility Center. I'm going to be bringing on Dr. Munch here in just a minute to discuss your first fertility evaluation. We were originally going to have Dr. Probst do this webinar, but we had some scheduling issues. So Dr. Munch, who is from the Texas Fertility Center San Antonio location, will be doing this month's webinar. Just a few things before we get started. First off, this is part of our ongoing monthly series. We host these on the third Thursday of every month. And if you want to learn about more events that we have coming up, you can just go to txfertility.com and we have them all listed on there. In addition, the way this is going to work is Dr. Munch is going to spend about 20 minutes or so talking about your first fertility evaluation, and then she's going to spend the last 10 minutes answering questions. If you look to your right side, you'll notice that there's a little questions panel there. So go ahead and during the webinar throughout it, if you have any questions about infertility or about your first fertility evaluation, just submit them in there, and then she will try to get to as many as she possibly can before the webinar is over. And finally, the one thing I did want to mention, last month during our webinar, we did have a few technical issues due to some internet connectivity problems. So if that does happen during this webinar today, just know that we will be back on. Like if you see us, the screen all of a sudden goes black and it says that we're not here anymore, we haven't left. We're just trying to get the internet stuff figured out. So just give us a minute and we'll hop back on and finish the webinar. So with that, I will go ahead and bring on Dr. Erica Munch.
Hello, thank you guys all for joining this evening, and you get to see beautiful daylight here in the room because of daylight savings time. So glad you're still up and you're probably exhausted from a long day, but we're so thankful and excited that you joined us here this evening. So my name is Dr. Erica Munch. I'm one of the physicians at Texas Fertility Center here in San Antonio. And tonight we're going to be spending time talking about your first fertility evaluation. So I first want to say congratulations, to signing in and signing on and learning about your fertility evaluation, because I think it's a really important first step. And it can be a scary one and a challenging one. And it's certainly not my first fertility evaluation. So know that you're in good hands when you're getting to see your doctor. And though you may have some apprehension about that first visit, this is our opportunity to answer your questions about things. So feel free to type them in. I'm going to spend the first 15-20 minutes just talking about what we do during the evaluation. And if I see some salient questions pop up, I'll answer them during that time, but mostly we'll focus on Q&A towards the end. No question is too silly or too stupid, so feel free to ask away. This is in the privacy and convenience of your own home, and your questions are anonymous, so I won't know who's asking them or where it's going to, but feel free to send those in. So basically, your first fertility evaluation is information gathering, both for you as well as for me as your physician. So when you're deciding that it's time to get things checked out, maybe you guys have been trying for a while, hasn't worked out, or maybe you know that there's a compelling reason that you're needing fertility evaluation. You might not get periods very regularly. Your husband or partner may have had a vasectomy and you know that there's no sperm there right now. Or maybe you're in a same-sex relationship and you know that there's part of the puzzle here that we need to help add. Either way, when you've decided it's time to call up the fertility doctors, we're a phone call away. Part of the first steps in taking that fertility evaluation when you make your new patient appointment, at least the way our clinic works, is that they're going to collect your benefits information as far as your insurance and go through with you what's covered and what's not covered, because I know that's obviously a big part of what people are concerned about. Surprisingly, I think what surprises most people is that the fertility evaluation is almost always covered by most insurances, which is really nice. So part of our first steps as far as the fertility evaluation are kind of making sure you know where you stand and what you're going to expect at that appointment. So when I get to see you as the fertility specialist, it may be in person, it may be over telemedicine, right? We're trying to keep everybody safe and away from COVID, and everybody doing their part to wear masks and social distancing is great. I actually really like doing new patients by telemedicine right now because it gives us a chance to see each other without our masks. We get to spend a relaxed, easygoing conversation. You're not worried about who was just in the room or what you might catch in the next 15-20 minutes. And it's a really good chance for us to get to know each other. You're almost always together with your partner, or if you're single, of course, it's just you. And it's our chance to really get to know each other and for me to understand a little bit about what's going on and what your family building goals are. So really, for the most part, for most fertility evaluations, that initial meeting with the doctor is is a lot of time spent on history, right? So I'm trying to learn more about you and your body and how it works and what you've tried and what hasn't worked and what you're hoping to get out of the visit, right? And that doesn't involve speculums and it doesn't involve invasive exams, and it's just really a chance to really kind of know more about what's happening with you. So we talk about, when you started your periods, how regular are you getting them? Have you been using ovulation kits? Have they been working? Have they been super frustrating to you? You're waking up every day and it's never positive, and that can be frustrating. Talking about any kind of fertility testing that you've already done, right? So some people have done testing on their own or done mail order kits that they found online somewhere, or doing the home semen analyses. Some people have been to their OB-GYN already and have had some evaluation done either by blood work, ultrasounds, x-ray tests, and those sorts of things, and are already kind of bringing some things to the table. But you don't have to have those things in order to see a fertility doctor. Most people come to see us because they know something's wrong, and either their OB-GYN has sent them because they agree that something's wrong, or they have a pit in the bottom of their stomach and they say, I just don't know what it is. I can't point my finger to it, but I know that there might be something going on here. And that's the right time to call, right? So you don't always need a fertility, you don't always need an OB-GYN to send you to a specialist like me. So we talk about kind of what's currently going on with your reproductive parts of you. We talk about all the other parts of you that make you you, that don't have anything to do with egg or sperm, right? So talking about your past medical history. Have you had issues in the past? Have you had illnesses that might affect your fertility? Or sometimes you're on medicines that might affect your fertility or might have affected how your eggs and sperm are being produced. Talk about relevant surgeries that you've had, especially surgeries in the pelvis, like appendix being removed, any kind of surgeries done to help correct things like endometriosis or tubal scarring, and talking about uterine surgeries that people have had, like DNCs in the past, or have had issues with bleeding, needing surgeries to remove polyps or fibroids, or other kinds of things. And then we talk about, environmental influences, things like smoking, alcohol, medicines that you're taking, exposures to things that you might have in the workplace that you're worried about. Really trying to understand not only just you, but the environment that you're in and how those might affect fertility. And we do that for the female partner, and we do that for the male partner as well, because it's, it's a two-sided equation here, and we're trying to figure out all the relevant pieces of the puzzle that might help us understand things. So that's 90% of what we do at the first fertility evaluation, is a lot of discussion to kind of talk about what's going on and what might be relevant factors both in your body as well as outside of your body. The other part of the fertility evaluation that we often do at that same appointment or shortly thereafter is an ultrasound, right? Because at the end of the day, I'm a gynecologist and we do lots of things, right? And you have had experiences going to the doctor and doing pap smears and pelvic exams and things of that nature. But just like a cardiologist uses a stethoscope to listen to your heart, I need a way to evaluate your reproductive organs. You can't just do that by looking at somebody. So what we do is typically a pelvic ultrasound, which is a non-invasive way of being able to look internally without radiation to be able to see what's going on with your ovaries and with your uterus, because that's a really good way of us kind of setting the foundation, as it were, to make sure that we don't see any structural issues that might cause problems with infertility, like polyps or fibroids. Checking the ovaries and not only looking at the fact that they're there, but oftentimes even by that ultrasound, we can see the activity on the ovaries and give us a good sense of if you're where you should be for your age, right? Do you have plenty of eggs and lots of time, and we can do lots of different things? Do we think we might have to be on a more accelerated or expedited path towards getting pregnant because maybe you're on the side of maybe having more diminished ovarian reserve? So the ultrasound is a good way for us to be able to identify those issues, sometimes even before you leave that first office visit. Like I said, nowadays with a lot of us doing telemedicine for that first new patient appointment, one of the nice things about that is that you do not have to get that pelvic ultrasound that first day. I feel like the information we cover at that first visit is a lot, and sometimes people are just kind of ready to take a step back at that very moment. And the nice thing about it is you're in your home, you can click the button, say end appointment, and we're done, and you've had a good chance to kind of think about all the things we've talked about, and then get really excited about coming in for that first evaluation by ultrasound. And by then you kind of know what we're looking for, and you know what we do, and we've got our path moving forward. So the first fertility evaluation, again, 90% of it is talking and just trying to figure out what's going on, and then following up with either pelvic ultrasound. And then in a little bit, I'm going to go through the tests that we do, because those are helpful in taking those next steps to figure out what we can do. Like I said, some people I know have questions or concerns about how much the fertility evaluation costs. Certainly, again, that kind of depends on whether or not you have insurance that your clinic participates with, and whether or not your insurance covers fertility benefits. If you don't have any insurance at all, just like anybody going to see the doctor, they should be able to offer you information when you call up to schedule that appointment, exactly what to expect as far as cost for those appointments. Sometimes some clinics will roll kind of all the things up into one. Sometimes they'll do more of like a individual pricing for the different things you may need. You may need this, you may not need that. You shouldn't have to pay for all the things you don't need. And really, you'll just kind of get a sense when you call to make the appointment what you'd be looking at. As far as other financial questions, I would certainly defer those to the wonderful patient account representatives that work at not only my clinic, but other clinics, to be able to give you a better idea about your insurance and what things are covered or not. But for me, from a medical perspective, we talk about you and what's going on, and we don't let insurance tell us what we're going to do as far as what is the most medically appropriate thing. So pelvic ultrasound, and talking about your history. I have one question as far as things in your medical history that might cause infertility or affect fertility. So let's think a little bit about medical illnesses that can result in infertility, right? So some people will have had a history of cancer. And if they've had cancer before and they've received medications called chemotherapy to affect those rapidly dividing and sensitive cells, chemotherapy can affect ovarian reserve, right? And ovarian reserve can be diminished with medicines like chemotherapy. It can also be reduced through medicines that are sometimes used for other medical conditions, especially things like lupus or other kinds of medicines that that work in certain ways that affect egg cells. So when we take your history and we evaluate that, we're trying to see if there's any medicines that could affect ovarian reserve or the bank account in the ovary. There are some systemic illnesses that can cause issues with fertility as well. Some types of endocrine problems like hypo or hyperthyroidism, so overactive or underactive thyroid, can cause issues with people getting regular cycles. It can affect the chances of miscarriage, and it can affect the way that your body responds to certain treatments. And so anytime that anybody has a medical condition, in general, we want to know that it's well managed, and that you're under the care of a specialist that's able to help get you to where you need to be. Some people have diabetes, right? And people with diabetes can certainly become pregnant, right? But we want to make sure we're doing so in a safe way. And sometimes being diabetic in certain situations can put you at more risk of having a high risk pregnancy. So uncontrolled diabetes or very poorly controlled diabetes can affect the ability of you to have it can affect and increase the risk of birth defects. And that can be birth defects in the heart or in the limbs. But certainly with uncontrolled or poorly controlled diabetes, it puts you at a much higher risk for a high risk pregnancy, maybe with one with adverse outcomes. And so we definitely want to make sure that people know that their blood sugar is under good control prior to moving forward. Some people have kidney or liver problems, and of course, or cardiac issues, pulmonary issues. Being pregnant is like being on a cardiac stress test on the treadmill for 9 months, right? Except you can't get off. And we really want to know prior to getting pregnant that you're in the safest, best shape possible. So if you do have those comorbidities or medical illnesses, we want to make sure, again, that you're being managed for those and that everything is cleared for you to become pregnant. Because once you become pregnant, that's the last thing you want to worry about. And that's the last thing I want to worry about is being in a situation where now those medical illnesses get worse and you're pregnant. And now we got to worry about you and the baby. And that's not a position that we want to put anybody in. So we do evaluate for medical illnesses and things that could affect fertility. As far as surgeries, some surgeries can affect fertility. I always like to know kind of what surgeries that patient has had before, because it gives me a couple hints about what might be going on with the reproductive organs. Some people have had surgeries in the past for endometriosis. That's a pretty obvious one, right? They may have had surgeries to restore normal anatomy or to reduce cysts and those sorts of things. But in the back of my mind, I've got to think about any surgeries that have been done on the ovary. How might that affect that ovarian bank account number, right? And where might we be standing from? And again, do we need to think about a more accelerated path for somebody who might have more diminished ovarian reserve based on the types of surgeries that she's had before? Or let's say she had, a ruptured appendix when she was 20 years old, and it had a lot of, pus and infection on the inside, and she was hospitalized for a week for that. That might actually cause such significant scarring that it may be a factor in her getting pregnant. Maybe her tubes are blocked, right? And so that kind of tells me to go in a certain direction with looking at what might be going on with the tubes and whether or not we have a good place for eggs and sperm to meet. So certainly, it's my job to worry about those, not your job. And so if you do have any of those medical or surgical things, make sure that your OB-GYN and reproductive endocrinologist know about them. But like I said, it's our job to take that into consideration when we're trying to figure out the best ways as far as moving forward. Somebody else asked a question about, what would be a good result on an ultrasound, right? So what's a good number of eggs? What do I want to see? A good number of eggs is as many as your ovaries will make for us. So there's no special number that anybody needs to hit, because as you get older, your egg reserve declines. And so sometimes we see more eggs on the ovaries and sometimes we see less. And again, I'm trying to figure out, if this is age appropriate or if you have more accelerated diminished ovarian reserve compared to somebody else. Technically, we would like to see at least 10 follicles when we add up both the numbers together and give us a sense of fair ovarian reserve, but we certainly can achieve pregnancies with less than that. But again, to me, it just kind of sticks in the back of my mind. I say, now we may have to work a little bit harder, use higher doses of medicines to get where we need to be as far as egg development. So an ideal ultrasound, we'd do the ultrasound, we'd see absolutely zero fibroids, no polyps, plenty of eggs on the ovaries, beautiful anatomy. But not everybody's body reads the textbook, right? So as long as we see the structures we need to make a pregnancy, then that's the best answer we have. I'm going to switch now into talking a little bit about the types of tests that we order after that first fertility evaluation. So after you speak with your doctor about your history, and let's say we do an ultrasound, or even if we haven't, we know that there's those parts of the puzzle that we all learned about in high school biology that we need to cover to make sure that we've got everything in good working order, right? So in order to make a baby, I need more or less 4 things. I need ovaries that do their job to make a good quality egg, and hopefully on a schedule that I can predict. I need tubes open, so I have a place for eggs and sperm to meet. I need a good uterus that can hold a pregnancy and doesn't have anything standing in the way. And I need enough sperm to get the job done. And so our fertility evaluation is really focused on those 4 parts of the puzzle, right? So when we look at ovaries, a lot of times we do that by blood work in conjunction with the ultrasound, the pelvic ultrasound. So in addition to just looking at the ovaries and seeing their activity, we can actually check hormones, both from what's being made by the ovary, as well as what's being made from the brain, to see how hard is the brain working to get the ovary to do its job. The other things that we look at by blood work are hormones that are important for pregnancy and that might interfere with regular ovulation or progesterone production. So those are the types of exact blood things that we order depend on your situation and your history. But in general, we're going to order something called an AMH, or anti-Müllerian hormone. That's the gas tank on the ovary. It tells us how full it is with eggs. FSH is a hormone that checks how hard the brain is working to tell the ovary to do its job. And then estrogen is the one that's being made by the ovary to say, how well is it doing its job? And we like to see those numbers together to see what that relationship is. We check thyroid hormone. Sometimes we'll check prolactin, which is a hormone that we all make, but sometimes can cause problems when it's in excess. We check thyroid hormone, a couple other hormones, again, depending on your situation. But the biggest ones are looking at ovarian reserve and that relationship between the brain and the ovary. The way that we look at the ultrasound as well as the tubes is both by ultrasound as well as an X-ray study called a hysterosalpingogram, or HSG. That's the X-ray test that you've maybe read about, had nightmares about. It's the test where you go to the radiologist and they look through a fluoroscopy study to check the tubes and make sure they're open. What they do is they put a little dye inside the uterus and they push it up so that it goes into the tubes, and that way we can see if the tubes are open, and then I have a good place for eggs and sperm to meet, right? It's a little bit crampy. It's not a super fun procedure, but you take some ibuprofen beforehand and it's over within a couple of seconds. And it's a nice way of us being able to assess and make sure the plumbing is open, so to speak, without having to do surgery on you to answer that question. I find that test is particularly important for patients that have had prior surgeries or reasons that I'm worried about scarring, previous STDs, or other infections in the pelvis that might have caused some tubal scarring, especially for patients that are considering donor insemination. So if they're going through the efforts of finding a sperm donor or somebody that is going to help them achieve a pregnancy, and sperm is not always free or readily available, I think it's really important to know that we've got a fair chance of getting pregnant each month. And that's another good reason to have an HSG done. It tells us a little bit about the uterus, but again, the ultrasound in the office can tell a lot about the uterus, and we get to put our eyes on that directly. And so that's really the female part of the evaluation. And if we've got our male side of the equation, they get off a little bit more scot-free. They're really the first study for them, and sometimes the only study for them, is a semen analysis to check sperm numbers, to make sure that we've got plenty of sperm, they're moving and swimming in the right direction, they're normally shaped, and we've got plenty of sperm getting to where they need to be. The semen analysis is something that's non-invasive. It can be done pretty easily. Many men will choose to collect sperm at home and bring it up to the lab, or they can collect on site. There's usually an area available for that. So whatever is easiest for the couple or for the individual is kind of the way we go with that. And that way we have a real good sense of what's going on. Just because there's fluid doesn't always mean there's sperm in that fluid. That's something that, again, I think is important to note, because some people will say, there's not been a problem and everything seems fine. And then we end up finding out that there are some sperm motility issues and things that we can help. Sometimes by doing things like insemination, where we're concentrating the sperm down into a small amount of fluid we can put up into the uterus. Sometimes we see a pretty significant issue and we want to make sure we talk with our colleagues across the aisle, so to speak, the urologists, and they're better able to evaluate, do a physical exam on the gentleman, make sure that he doesn't have any obstructions or problems that would be causing low sperm issues, and sometimes even prescribe medicine to help with that. I think it's an important thing. The semen analysis, I think, is an important part of that new patient evaluation, to be done earlier than later, right? Because especially when I see women jumping over so many hoops and hurdles to get to where want to be, I think it's a relatively easy thing to ask of the other half, so to speak. And then also, sperm take 3 months to make. So if we find an issue, I'd rather start on it now and get those numbers to be where they need to be, so that way we're ready to go in an optimal way, rather than, try an X, Y, and Z, and 6 months down the road, we find out, hey, there's an issue over here and we should have checked this out earlier, right? My job is to leave no rock unturned and no T uncrossed, right? So you're relying on me to look at everything. And part of that first evaluation is to look at everything. So I'm going to, I think, finish with that part of it, because that's really what we do in the evaluation, and take some questions. So there is one question here about having severe endometriosis and a blocked tube on one side and being at a high risk of ectopic pregnancy. And that is true, right? So if you do have a tube that is full of fluid called a hydrosalpinx, you can be at higher risk of ectopic pregnancy. Some people have questions specifically, do I need IVF, right? And that's actually a different webinar for a different day. But IVF, or in vitro fertilization, is when we take the eggs outside the body and we introduce them to sperm in the laboratory, and then the resulting embryo that comes from that fertilization will go back into the uterus. So we're bypassing the tubes. Now, the reasons that IVF would be automatically required for somebody is if their tubes are blocked, both of them, there's no chance that they're getting pregnant at all, or they've had a tubal ligation. or if they are doing a what we call a reciprocal cycle, where it's a same-sex female couple or even a male couple. Obviously, if we're using eggs from one person and a uterus of somebody else, okay, that is a situation in which we need to use IVF. Or if there's such low sperm numbers that we don't have a realistic chance of getting sperm up into the tubes, or the sperm numbers are so low that the urologist has had to do a surgical sperm extraction from the testicle, those are reasons that we have to use IVF. If you have at least one of your tubes open, you may not need IVF to get pregnant. Certainly IVF has higher chances of pregnancy, but again, and there's a different webinar, which I may have hosted once, that's called, do I need IVF? And it's a really nice way of being able to go through, absolute indications for IVF and relative indications for IVF. But remember, my job is to make sure there's ovaries, there's a tube to allow eggs and sperm to meet, that there's plenty of sperm to get there, and that there's a uterus to hold that pregnancy. So if you have all of those parts, pregnancy can be achieved, just a matter of how much extra help along the way. Sometimes that help involves IVF, and sometimes it doesn't. So I had a question about egg freezing, thinking about freezing eggs and the process of doing that. Egg freezing involves the same history that I was talking about, but of course, a lot of people freezing their eggs may not have a partner that they're going to freeze with, so we don't really worry about the sperm side of the equation. But I definitely want to check ovarian reserve. I want to do the same numbers testing that I would do for anybody in that situation. And typically we'll have you come in for an ultrasound as well, so we can check, make sure the ovaries are accessible by ultrasound, because that's how I'm going to be draining them, and checking everything out. We don't worry so much about fibroids in the uterus at that point, unless they're obscuring my ability to see the ovaries, because really when we're freezing our eggs, the only part of that equation that we're worrying about right now is the eggs. And I don't really care if the tubes are open, and I don't really care if the uterus is in great shape for pregnancy at that moment. I will later. I mostly want to know I can get to the eggs and that we've got a good bank account. And if our bank account is lower, again, that helps me adjust the dose of my medications as needed. So, but other questions? Well, lots of questions about IVF. I feel like a lot of you guys have been told about needing IVF. Again, IVF is a great tool. It's one of many tools we have in our box. And so sometimes it's the first tool we reach for. It's usually not the only tool in the box that we can use though. So I highly encourage you to speak with your REI or OB-GYN about whether or not IVF is something you need. But like I said, if you have ovaries that can make eggs, if you have a tube that is open, if you have a uterus that can hold a pregnancy, and you have a way to get sperm in there, IVF is usually not the only tool in the box that we have. Cholesterol, that's a good question, and other things, and kind of thinking about just in general, because I see a couple of questions about this, about how age affects fertility and what we expect during the first fertility evaluation with that. So we know that age does affect fertility. And even though we're fabulous, going into our late 30s and 40s and upper 40s, our ovaries don't really get the message sometimes. And our ovaries were, they're full of eggs that were made before we're born. And as we get older, that number, the basket of eggs declines. Okay. And we get to menopause, we run out of eggs. And the quality of those eggs actually goes down too. And it doesn't matter if you're, in perfect shape and you eat broccoli every day, and you take all your prenatal vitamins and you exercise 6 times a week. Unfortunately, the ovaries don't work like that. And the DNA that's inside those eggs becomes less stable with time. So as we get older, the chances of getting pregnant decline. And the chance of having a miscarriage or a baby that has Down syndrome or trisomy 13 or 18, it goes up pretty significantly. The biggest window for change happens after the age of 37 up to 42. It's always gradually declining, but after age 37 and 38, it starts to decline more rapidly. And that's why I think it's really important to get your fertility checked out sooner than later and make that first fertility evaluation, because these are things that we were not taught in high school. As far as what happens with our ovaries as we age. Sometimes people, I'm going to answer the cholesterol question real quick and then go back to that. Cholesterol, elevated blood sugars, triglycerides, those things do affect your health and how healthy your pregnancy will be when it comes to thinking about cardiovascular disease or risk of heart attacks or other complications while you're pregnant. Having high cholesterol in and of itself doesn't usually affect your ability to get pregnant. The other thing I was going to say about diminishing ovarian reserve is that as we get older and our eggs are less likely to work, some people will be able to, use their own eggs for pregnancy. Some people may really struggle to find the right egg and sperm combination using their own eggs to be able to carry a pregnancy, in which case those patients oftentimes will go to the route that we call third-party reproduction, which is when we use a donated set of eggs to help us establish an embryo that the person can successfully carry. The uterus, as long as it sees the right hormones, can work well into your 50s. So even if you've gone through menopause, you can still oftentimes carry a pregnancy. Our professional society has guidelines about the age at which you can carry a pregnancy safely anymore, and it's kind of in the mid 50s. But prior to that, egg decline happens, and oftentimes after the age of 43, 44, 45, it becomes really difficult to find the right egg and sperm combination using your own eggs. Not to say it can't happen, just becomes really, really difficult. And so for some people, they'll go through a lot of fertility treatments to try to find that right egg. Some people will try, and if they're not successful, go to using a donated egg. And some people might automatically just go to a donated egg. And depending on what your family building goals are, all of those can be very appropriate next steps. Let's see. As far as sperm morphology, that's a good question. So what happens when the sperm analysis comes back abnormal, right? So it really depends on how abnormal it is and what the underlying factors for the male are. In the setting of normal concentration, normal motility, and normal volume, we don't worry so much about the morphology issues because they're not always predictive of an inability to get pregnant. There's probably people walking around town that have isolated morphology issues but haven't had any real difficulties in getting pregnant. So oftentimes the urologist won't have a specific medication that's given to help with that. Now, if we do see that the motility is low or the concentration is low, then there might be medicines that can be used to help augment sperm numbers. Not testosterone, please. Public service announcement: do not take testosterone if you're trying to get pregnant, because that will actually lower your sperm numbers, and we don't want that. We want as many sperm there as we can get, but there are other ways to help elevate testosterone as well as elevating sperm production. So if it becomes, again, more complex at that point, seeing a urologist to help look at those underlying causes is the best way to do that. If we don't see any sperm at all, then what we'll do as the REIs, and I think there's a question here about azospermia, which is a lack of sperm, not a lack of fluid, but a lack of sperm in that fluid. The next best steps would be to have the reproductive endocrinologist help with getting some labs drawn for your husband. Usually those are labs that the urologist will want to see, and certainly the urologist can look at those right off the bat. I like to try to do it in advance for my patients, so that way when they go to the urologist has the results, they have the history, they have the gentleman standing in front of them, and they can do the exam, and they now have the blood testing results, and they can come up with a game plan right away rather than kicking the can down the road a couple more weeks and saying, let's do this, that, and the other. The blood work is typically done to see what is the testicle doing, what is the brain doing about that, and what are the chromosomal influences that might affect sperm production, specifically looking at something called a karyotype and certain chromosome deletions on the Y chromosome that makes sperm. So those are the next steps for somebody that has azospermia. Sperm quality actually don't decline as much with age as women's eggs do with age. So that's, again, another unfair about this process, is that with women, our eggs were made before we're born. And so very, very naturally, as we get older, the age of the egg declines, and the quality of the genetics on the inside of that egg decline. Because sperm are being continuously produced, men don't see a decline in fertility nearly as often as women do. Now, men can have, primary testicular failure and an absence of sperm, and some people's sperm counts go down and down and down to zero. It doesn't happen very often. It's important to get that checked out. But in general, most men's sperm production will stay relatively sufficient to achieve pregnancies well into their 50s, 60s, 70s. There's other things that go into that, other risk factors to consider with older parental age from a paternal side of things, but they don't have the same kind of DNA decline that women do in our eggs. So A lot of people, a good question here being brought up as far as the vices that we have and how they may affect things. So I have patients talk with me about, the fact that they used to smoke in the past. They will tell me about how much alcohol they've had. They will tell me about the termination of pregnancy that they had, oftentimes in tears, right? Because they don't know what, ghosts in the closet are going to come back to haunt them, or skeletons in the closet come back to haunt them when it comes to fertility. And I would like to reassure you that there are very few things that you've done in the past that could cause an issue with fertility. Okay. Having a termination does not affect your chances of getting pregnant in the future. Okay. That's a given. As far as alcohol use, again, we don't advise right now more than about 5 to 7 drinks over the course of the week. But if you've had alcohol dependence issues in the past, it's unlikely to have affected ovarian bank account here and now. We don't want you drinking alcohol when you're pregnant. We'd rather you not drinking too much alcohol when you're trying to get pregnant. But I'm not aware that there's data to suggest that heavy alcohol use in the past can affect ovarian numbers or your ability to get pregnant. Now, we do know that smoking, unfortunately, is the only other thing besides age that will decline your ovaries faster than age and chemotherapy. So if you're smoking, use that as a highly convincing reason to please stop smoking now, or to reduce your intake, or do whatever you can, get on medicines to help with that. Talk with your primary doctor, call the 1-800-QUIT-NOW number. Anything you can do to save that bank account in the ovary is very important. And so I would highly suggest, if you are currently smoking or using tobacco, that's really the only other thing that can affect ovarian reserve besides age. So I'm going to take one more question and then we're going to call it good for tonight. One person was asking about freezing your eggs at an earlier age and then trying to get pregnant later and how that works. It's a really very prescient question. With egg freezing, the way that it works is that we're basically recruiting eggs that your body was going to use right now anyway, right? So ovary starts out with lots of eggs each month. Only one makes it out of the gate. The rest of them die off. When we do an egg retrieval for somebody who's freezing their eggs, we're trying to get more of those eggs to make it to the finish line. So we don't use up your eggs any faster. We don't make you go through menopause earlier. We're just trying to be more efficient with the eggs that you're making. And the benefit there is that you can cryopreserve or use those eggs in the future and have the same chances of pregnancy as you did when you froze the eggs to begin with. So some people know, hey, I'm at this part of my life. Maybe I don't have a partner. I have a partner I'm not really quite sure he's going to be the one I'm going to parent with in the future, or they're potentially ready for children in the future, but just not right now. But they know that clock is ticking, and it starts to tick a little bit louder when you get to be 35. So what happens is that they will go through a process of freezing those eggs. They will cryopreserve the eggs, or sometimes embryos, and then be able to use them later. And like I said, remember, the uterus doesn't really care how old you are as long as it sees the right hormones and it's safe for you to get pregnant. So when you're getting pregnant using embryos or eggs from an earlier age, even if you're the older age, the chances of getting pregnant are that of the younger age. So if I freeze my eggs when I'm 35, and then I'm 45 and I decide I'm going to use those eggs now, my chance of getting pregnant is that of a 35-year-old. My risk of miscarriage is that of a 35-year-old. My risk of having a baby with Down syndrome or trisomy 13 or 18 is that of a 35-year-old, right? And so that's actually a really very forward-looking way of helping protect your fertility interests moving forward. And for some people, that makes a lot of sense. After that first fertility evaluation, maybe they say, you know what, maybe now is not the right time for pregnancy, but I'm glad I know these numbers, so that way I can do something about it and protect my fertility moving forward. So with that being said, I appreciate you guys' questions tonight. Thank you for joining us on the webinar. Please look at txfertility.com for our website to look at upcoming fertility webinar topics. I do know that needing IVF is a hot button one that I know that a lot of people will look at. We have one about people who've had their tubes tied and looking to see if they need IVF or doing tubal reversal makes more sense to them. We've done one recently on polycystic ovary syndrome. We do some on third-party reproduction, specifically talking about donor eggs, donor embryos, and gestational carriers. So keep in touch with us and let us know what you think. Thanks so much for joining us tonight. Have a good night.